Well, thanks everyone for, first of all, I'll thank you again after Sally's talk for attending the course today. It's been, I think, really tremendous. But the best may still be to come. Sally Hodder is a professor of medicine. Sally has been a real leader in HIV for decades, and not as long as some of us. But Sally is wonderful. She's at the West Virginia University, right in the middle of a lot of the issues that she's going to address, the coexistence of the HIV and the opioid epidemics, and we'll address that and help bring us up to speed. Sally, take it away.
Thank you. Can you hear me?
Yep.
Okay. All right. Well, thanks very much. HIV and opioids are really deadly synergies. My disclosures are shown on this slide. And the learning objectives are really to talk a bit about the epidemiology, to discuss some of the prevention strategies, to delineate barriers and how perhaps we can develop some solutions to those. And then the organizers asked me to add a COVID slide, and so that is at the very end. This is no surprise to anyone. The opioid overdose death rate in the 21st century, it started up slowly in the early part of the 21st century, but has skyrocketed since 2013. Noteworthy is that more recently, we have seen a downtick with by several percentage points. Whether that will continue, I think, remains to be seen. If you look at the overdose death rate by age, it's really gone up in all age groups, but most markedly in those groups between the ages of 25 and 64. And if you look back in 1999, you can, compared with 2016, you can see the explosive nature of really drug overdose mortality. The dark blue delineates an age-adjusted overdose rate of 2, with the dark red representing greater than 30. And as you can see, there's been a sea change in just a 17-year period, with high concentration of mortality in Appalachia and in much of the West. In this slide, I've juxtaposed the age-adjusted overdose death rate map with that of poverty. And again, you can see with the magenta color on the panel on your right, those are counties in which a third to half of residents live in poverty. And clearly, you can see the association of drug overdose deaths with poverty, particularly, again, in Appalachia and some areas of the West. Case in Deaton, 2 Princeton professors have coined the label deaths of despair to describe increases in mortality due to drug overdoses, suicides, and alcohol-related disease. And these deaths of despair primarily occurred among white, non-Hispanic persons without college degrees, and ethnographic studies suggest that actually hopelessness and loss of purpose are components of the decreasing life expectancy that we now see in the United States. On this slide, you can see that there were really what's described as 3 waves that early on in the early part of the century, prescription opioids accounted for most of the overdose deaths, with the rise of heroin in 2010. But more recently, in 2013, there has been an explosion in synthetic opioids that have really greatly contributed to the mortality of people who inject drugs. Fentanyl, in particular, is a concern since it is available as a powder. That means that it can be prepared without heat. No heat means that there's no inactivation whatsoever of HIV. Also, there's less rinsing of syringes with fentanyl, and so the syringes don't clog. Because of fentanyl's quicker onset of action but shorter duration of effect, it's been associated with more frequent injection and needle sharing, which means it could be associated with increased incidence. And you see that fentanyl is 50 to 100 times more potent than morphine, and really the fentanyl and with subsequent other synthetics, carfentanil and so forth, has really driven the overdose death rate through the ceiling. Now, the face of HIV in people who inject drugs has been changing. Not shown on this slide, but early on in the HIV epidemic in the 80s and 90s, people who injected drugs accounted for up to 30% of individuals who developed HIV infections. But subsequently, with an understanding of the virus and of harm reduction, this has come down, and you see there starting in 2010, it has actually continued to come down until 2014 and 15. There was a slight uptick in 2015, which came down, and we'll have to see where this goes. But I think noteworthy is that in 2015, there was really an inflection where individuals who are white and younger individuals and individuals who lived outside of metropolitan centers were those folks who injected drugs who were most likely to get HIV. And this slide just shows much the same thing for 2018 from the CDC. You see that in men, 41% of those people who injected drugs who developed HIV, and in women, 50% of women who acquired HIV, women who injected drugs, were white. And that was really quite a change. And actually, intravenous drug use among Black, African Americans, or Hispanics in recent years has actually decreased. Now, if we look at, and most, I'm sure everyone has seen this, but in 2014 and 15, there was an outbreak in Scott County, Indiana, 181 cases, 5% of Austin, the town there, became infected, 43% of whom were women. Most were injectors of prescription oxymorphone. 92% were co-infected with hepatitis C. But this occurred in the context of high unemployment, high poverty rate, and 20% of these individuals were without a high school diploma. This was a, poster case of the deaths of despair, where you see sort of high unemployment, high poverty, really preceding injection drug use. And in this case, what ensued was an HIV outbreak. Rural communities, though, have not been the only places where we've had emergence of HIV in populations of folks who inject drugs. In Lowell, Massachusetts in 2015 through 18, Lowell and Lawrence are two urban areas in northeastern Massachusetts with high rates of both poverty and opioid overdoses. There was an outbreak. Interviews that were conducted in 34 of the 129 cases revealed that all of those individuals actually reported being homeless. Again, 43% of the individuals in that outbreak were women. Moving to Seattle, HIV also emerged in Seattle, Washington, among homeless people who inject drugs. I would draw your attention to the fact that of the women, 73% reported exchanging sex for either drug or money. And I think, we all know that Seattle, Washington has robust treatment and prevention programs, but actually in disenfranchised folks who were homeless, who injected drugs, those programs were not reaching them. And so it really doesn't matter if you're in the middle of West Virginia where there are no programs, or in the middle of Seattle, Washington where the programs don't get to you, the result is the same. And over the past couple years in Cabell County, West Virginia, We have had an HIV outbreak. Actually, it's 82 cases on the slides, but I checked yesterday and we're up to 93 cases, unfortunately. Again, 92% white, 40% women, about a third of whom reported exchanging sex for money or drugs. And so, in that setting, I think what is we have to ask ourselves, we have tools, we have multiple tools that we know can prevent HIV acquisition among people who inject drugs. So what are some of those tools and how can we use them? Medication-assisted treatment has been shown to be effective to treat opioid use disorder. But less than 10% of individuals who have opioid use disorder can attain long-term abstinence without medication-assisted treatment. There are 3 approved agents shown there, methadone, which is a mu receptor agonist, and it is available as an oral tablet or liquid, and is required to be dispensed by programs really with certified substance abuse and mental health experts. Buprenorphine is a partial agonist. There is potential for abuse, and therefore most often it is combined with naloxone that discourages injection due to the precipitation of acute opioid withdrawal. Both methadone and buprenorphine have demonstrated in various trials significant retention in treatment, decreases in illicit opioid use, and decreases in injection behaviors. But, I don't think that medication-assisted treatment is enough. In the HPTN Study074, this was a study among 502 participants who were HIV infected and 806 of their partners. And this study randomized individuals to standard of care, which included antiretroviral therapy and access to medication-assisted treatment, versus those 2 things plus system navigation and psychosocial counseling. And you can see at week 52, there was a higher proportion of suppressed viral load in those who also got system navigation and counseling. MAT use and retention in the program was higher. And I think most impressively of the partners, there were 0 cases of transmission to partners in the intervention arm versus 7 cases in the standard of care. And you can look at the probability of death, the Kaplan-Meier shown on the right. And again, you can see that probability of death was higher in standard of care, which really suggests that, again, it's not just having programs that are there, it's really having wraparound services that can engage individuals who inject drugs in care and really sort of holistic care and navigating the system. There are many barriers to MAT, a few are shown here. It's estimated that 1 to 2 million persons in the U.S. have opioid use disorder, yet fewer than half are likely receiving MAT. Federal waiver is required to prescribe buprenorphine, and though there's been some improvement in recent years with nurse practitioners and others being allowed to obtain a waiver, there still is actually that hurdle to cross. And there's actually been recent studies that individuals who have waivers often don't prescribe to the numbers of patients to which they could. There's limited access to medical care for people who inject drugs. I think an important example is in Kentucky, where the ACA-mediated Medicaid expansion resulted in providing health care insurance to 87% of persons who use drugs, whereas before the expansion it had been 34%. As you know, many states do not have Medicaid expansion, and I think that that is really problematic for individuals who inject drugs, who need care and need treatment. There are other structural barriers shown there, not the least of which is stigmatizing environments in clinics. Moving on, I think HIV counseling and testing is important. This slide, there's a lot of stuff here, and I apologize, but I wanted to get it all on one slide because I think it's all important. Every 3 years, the CDC conducts the National HIV Behavioral Surveillance, or NHBS study, that surveys people who inject drugs across the U.S. In 2018, over 11,000 folks who inject drugs were included in this study in 23 U.S. cities, and 6% tested HIV positive. As you know, it's recommended that individuals who inject drugs should be tested for HIV once a year. Actually, the NHBS found that only roughly half had been tested in the past 12 months. The other fact was that overall about a third had used a syringe after someone else used it. The other thing that I think is important to remember is that condomless sex among women who inject drugs is common. The NHBS reported that among women, vaginal sex, a condom was used 75% of the time and 27% of the time in anal sex. And so when we think about, pre-exposure prophylaxis, we'll talk a minute about a study in injection drug users, but I think we should not forget that actually, I think sexual transmission is extremely important among persons who inject drugs. There's lots of barriers to HIV testing, lack of healthcare access, as we've discussed, poverty, stigma, just really going into a clinic where, the environment and the atmosphere may not be one that welcomes individuals who inject drugs, and also chaotic lifestyles with high rates of homelessness, I think make it very difficult to, really get regular HIV testing and access harm reduction services. Moving on to another tool in the toolkit to prevent HIV, are syringe services programs. This is a meta-analysis of 12 studies that assessed the risk of HIV transmission. In these 12 studies, there was more than 12,000 patient years, and you can see that overall the risk was decreased. When they actually used what they thought were the highest quality studies, there were 6 of them, it actually decreased the risk of HIV acquisition by 60%. A recent study by Monica Ruiz and her colleagues assessed HIV surveillance data from Baltimore that's shown in this slide from 1985 to 2013. And as you can see, in 1994, Maryland law changed, enabling syringe services. And the study showed that because of that, almost 1,900 HIV cases were averted over 10 years. And the return on investment was almost $47 million. This same group also did a similar study in Philadelphia, which even showed greater numbers of HIV cases averted and larger returns on investment. Yet, despite data and science, the syringe service programs are not getting there. In fact, there was a recent a couple years ago, Dr. Gonsalves and his colleagues looked at Scott County, Indiana, and said, what if syringe services had been effectively available in 2013? Actually, the Scott, Indiana outbreak, which actually, by the way, is now up to 215 persons, would have been less than 56. And in fact, if the intervention had been implemented in 2011, there would have been very, very few cases. There probably wouldn't have been an outbreak. This is after the Scott County outbreak. The CDC looked at counties and came up with 220 counties, several of which are in West Virginia, that are vulnerable, that really had characteristics that would suggest that an HIV outbreak or hepatitis C outbreak was likely. Those are shown in blue here. The green shows the location of syringe exchange programs, and the orange is both. And you can see that there are many, many places where there are vulnerable counties, and yet where syringe service programs are not available. Moreover, if you look at the legality, you'll see the red states shown there. Syringe service programs as of 2019 are illegal. And actually, if you look at the light blue, like West Virginia, they are locally permitted. But in fact, in West Virginia, I'll just tell you a little bit of story there. So there was a very good syringe services program that was operating in the Charleston local health department. Charleston's capital, West Virginia. They were serving 5,000 clients, and it was actually forced to close. Subsequently, you may not have read about this, but there are increasing cases there. I looked yesterday, and it's up to 31. Huntington does have an active syringe exchange, but they have been under pressure, and there has been a move to actually have them revise some of the things they do to make it a little more, in my opinion, difficult for clients. And another syringe exchange program over in the northern part of the state in Clarksburg recently was forced to close. There was a bill introduced in the West Virginia legislature last year. Thank God it didn't pass, but the bill that was introduced actually would have made it illegal to have syringe exchange programs in the state of West Virginia. State of West Virginia has the highest overdose death rate. I mean, opioid use is a huge problem. We have ongoing HIV outbreaks. We have the science that syringe services programs work, and yet, I think that there is not the political will to really to move forward. And in fact, the political will is moving the other way. And we shall see what happens in the future with that bill. Moving now to PrEP. There's been one study of pre-exposure prophylaxis among people who inject drugs. It was done several years ago in Bangkok, enrolling more than 2,400 HIV uninfected persons, 20% of whom were women. They were randomized 1-to-1 to tenofovir versus placebo, and there was a 49% overall relative reduction of HIV incidence. Tenofovir was detected in 2/3 of participants in the tenofovir group, and in those participants, the HIV reduction was 74%. And though the trial was not powered to assess efficacy by subgroup, I'm always really interested in the fact that actually among women, who constituted 20% of the study, that the efficacy was higher. It was 78%. And in Dr. Buchbinder's session, we were talking that, yes, tenofovir pre-exposure prophylaxis works in women if they take it. And I think in this study of women who inject drugs, it clearly demonstrated efficacy. This study has been, sometimes criticized for the fact that actually syringe sharing decreased from 18% at baseline to 2% 12 months later, questioning the generalizability of this data. Also, you can see on this Kaplan-Meier of the probability of HIV infections occurring. The placebo is in blue, tenofovir in red, and you can see that the curves did not diverge until month 36. And it is it remains unexplained, though the investigators in that study have used various statistical methods, and they say that, really this is, when you do these methods, there was not a change in the efficacy over the observation period. I think, though, the thing to understand is this has been the only study conducted of pre-exposure prophylaxis among people who inject drugs. I think that it's, though, We pointed out earlier that one needs to consider the fact that people who inject drugs are also at risk of sexual acquisition of HIV. I think it's going to be critically important for the new agents to really include people who inject drugs in the studies to really have an understanding, do they work? Obviously, if you're sharing syringes, it is a different route of HIV transmission. But right now, this is the only study we have. There's been concern about adherence to PrEP. The Bangkok study was quite good, but other studies have shown poor adherence, particularly among individuals who are younger, women, individuals who used heroin or stimulants, and meth is on the rise. In fact, much of the fentanyl is actually laced with meth these days. PrEP adherence was worse among individuals who had mental health comorbidities, transactional sex, and homelessness. And those are just the populations where we've seen outbreaks of HIV. Barriers to PrEP, there are many. I've discussed one of them, but another is low awareness among people who inject drugs. In fact, in the Cabell County outbreak, there was a recent study, a qualitative study, that looked at awareness of PrEP, and actually 69% of those folks had not previously heard of PrEP. There were issues of the healthcare access, chaotic lifestyles, and really, I don't think we can underestimate the unwillingness of some healthcare providers to prescribe PrEP to persons who inject drugs. I'm not going to read this slide, but I did want to make you aware that in January, the National Academy of Sciences, Engineering, and Medicine had a very good report about how we can improve opioid use disorder treatment and infectious disease services. And the bottom line is that we need to integrate wrap services around folks who are at risk and really connect the health and criminal justice systems. It is really worth a read. The first couple of pages outline all the barriers and propose solutions, and it's really quite thoughtful. Now, turning to COVID-19 and opioids, a pandemic and an epidemic collide. It's unfortunate just at the time, in my opinion, that we were beginning in this country to coalesce around, effectively addressing opioid use disorder, drug overdose. The first slide I showed a tick down. This is just the time now that we have COVID, and my worry is that in many ways it may make things much worse. The organizers asked me to give a slide about what will the impact be. The true answer to that is we don't know, but it's likely to not be good. I think the impact will be at multiple levels: housing instability and incarceration, both of which are issues for people who inject drugs, increase the risk of COVID transmission. Challenges to medication, getting medications for opioid use disorder, though I will say federal requirements during the pandemic for methadone procurement have been relaxed, and the DEA is permitting teleprescribing for buprenorphine. I think harm reduction services have been more difficult to access. There have been some that have had to close down because of many of their staff and clients got infected. At the IAS conference, the Fenway Community Clinic presented data. Now, these were not just in people who injected drugs, it was overall, but new prescriptions from January through April decreased 72%, and PrEP refills lapsed 191%, which does not bode well. I think care may be deprioritized for people who inject drugs due to healthcare institutions perhaps having stigma, but also the overwhelming of health institutions that we've seen in many parts of this country. And also isolation for people who inject drugs or anyone with substance use disorder may really preclude the social support so critical to recovery. And then finally, I think the severe economic downturn, stress, anxiety, hopelessness will likely worsen the opioid epidemic. Those are just the things that actually we have associated with why we got into the opioid epidemic in the first place. So I think this is really going to be a critical time, and I think that more attention needs to be paid for how we can mitigate some of these negative effects among people who inject drug. So in conclusion, I think the epidemiologic patterns of HIV acquisition I've demonstrated have shifted in recent years. Science around medication-assisted treatment, syringe exchange are established, yet implementation is lacking. Women constitute nearly half of recent HIV outbreaks associated with people who inject drugs, yet focused studies, particularly among rural women, are lacking. New antiretrovirals for HIV treatment and prevention with infrequent dosing are, I think, really promising for folks who inject drugs, particularly those who may be homeless, where, you can't keep a jar of pills, but studies in these populations are needed. And finally, I think effectively addressing the root of the opioid epidemic is critically important but elusive. And I will stop there. Thank you.
I missed the clapping that otherwise we would hear at the end of each of these times. Thank you very much, Sally. That was spectacular. We have only a few minutes left for questions. There are a few on the Q&A, and some of them are just philosophy, right? Why do the authorities make it so difficult to prescribe meth when doctors can so easily prescribe narcotics for other things?
I wish I could say the world made sense, but it makes no sense. Though I will say, I do think that there has been a stigma that, substance use disorders, are a illness like any other. We've looked at the circuits and so forth, and yet I don't think certainly among many of our politicians who make the rules, and I think among some healthcare professionals, I think some people still believe this is a weakness of character or bad choices. And I think we really need to get out of it. Once you get out of that mindset, this is a medical disease. We can treat it, and we need to facilitate treatment, not make it harder. It's not like they make it harder to get cancer treatment, right?
Right. So another broad question. You mentioned in one of your slides that a program where standard of care was compared to a more aggressive intervention, including system navigation. The question is, tell me more a little about system navigation. What did that entail in that study?
Yeah, no, that's a good question, and you can look at the paper, but it was basically, I even think it's hard just if you're trying to get an appointment at XYZ clinic, making the appointment, getting transportation to the clinic, if there's available, how do you sign up for Medicaid if in fact Medicaid is available to you? Those were some of the things that the navigators did. And I think also it was a problem solver for individuals. And I think that that's what we really need. I think that healthcare systems don't make it easy.
Sally, this is my question. We've heard intermittently for a long time about the possibility of safe injection facilities. I don't remember you saying anything about that. Can you update us on? We had talked about Philadelphia, Seattle, San Francisco, and obviously Vancouver. Any more comments?
No, I think the political wins in the United States, and there was a lot of talk about Philadelphia, and to my knowledge, maybe somebody else knows more, that has not happened. And again, I think it makes so much sense because a lot of the reason that you have overdose deaths are because people, sort of are alone. They inject. It's been laced with God knows what. Nobody's there with naloxone. And even though there have been lots of great programs to, increase naloxone distribution, if you're alone, there's nobody there to give it to you. Not to mention the fact that safe injection facilities can really engage folks into the system, into MAT, sort of clean syringes. I just don't think we have the political will. my God, we have politicians that go around and say, well, people are older. If they get COVID, it's just what happens. We have to open up stuff. I mean, I really think that is the issue. And I think until there is, more value to the individual and an understanding that actually the science can really help prevent these things, and we all need to work together, including the politicians and the healthcare workers. I don't think safe injection facilities are going to happen. Certainly not in my lifetime unless something changes in West Virginia.
Yeah, I tend to agree. I'm sorry to say. I'm just going to make a comment. You talked about the data. The data we saw at IAS 2020 was striking in terms of the impact of COVID on, all of the ending the HIV epidemic and PrEP progress that have been made. I've also heard that there is a real concern that same things are going on the global HIV treatment programs, PEPFAR and the rest, and the Global Fund. The competition for resources and the other disruptions are really threatening to set us back substantially and all the gains that we've made for the last 15, 20 years. So people like your talk, Sally, and they're cheering for you, and I think that's great. One question, maybe this might be the last question, is one participant wants to know if you could remember just one skill that an HIV provider who's engaged and already prescribing PrEP and naloxone, what skill would you recommend we think about acquiring?
Well, it's not for me to say, but I do think if you're taking care of populations of folks with opioid use disorder, having MAT in the HIV clinic, and that's not only getting the waiver, being able to prescribe it. I think MAT, we say medication-assisted treatment. I think it's more than that. I think you really need, sort of competent mental health professionals, sort of social workers and so forth. But I think it's very important that we really sort of have one-stop shop for all this stuff.
Sally, thanks so much. Other question was recordings of this, and I think we'll get up to that in my comments. So, Sally, I want to really thank you. The audience loved your talk, as did I. Thanks.